coming up. The first thing I was going to talk about is that PCPEP program. And for those of you, has anybody heard about this program at all? No? Okay. So it's a program that's actually meant to be kind of at the initiation of that diagnosis. It starts at that diagnosis, and we'll talk a little bit about exactly what goes on with it. So it stands for Prostate Cancer Patient Empowerment Program, and even though it's a program that's offered, it's actually still part of a clinical trial, and it's been proven to be effective. But what we're doing now, and I'm one of the site investigator for Saskatoon. It was a program that was started out in Nova Scotia, and how it came to be is what I wanted to talk to you about, and also what exactly happens with it, and what are the benefits or potential benefits. So we're doing a phase 4 trial, and what that means is it's already been proven. There's been randomized controlled trials to show what it does and how effective it is. But now we want to know, this is all done in Nova Scotia, and what applies to Nova Scotia may not apply to Saskatchewan, may not apply to British Columbia. And so this is really about learning what may or may not work with this program in different sites. And it's sort of been the phase 4 trial is now across Canada and international as well. There's New Zealand's actually doing it as well. The idea, and this is sort of the brainchild of somebody named Gabriella Illy, and she's a researcher, and she spent many years in Toronto and then moved to Dalhousie and became a researcher. Her background is really research in mental health and disease, and how different diseases, specifically cancer, affects our mental health. And so she had done that research in Toronto, not for prostate cancer, but moved to Dalhousie and then decided to see whether or not, or what are the impacts of prostate cancer on health. We know what the physical impacts are, but there's also the psychological impacts, not just of prostate cancer, but any disease. But her goal was to really identify, what the impacts were on prostate cancer. And so that was the why. We'll talk about exactly what happens in the program, but how it all came about and it started with really support groups. And this is, I would sort of consider it like an enhancement, or not even enhancement, but what it has done in Nova Scotia is it really started at the support groups, and then with that when I explain exactly what it is, you can sort of see how it kind of enhances support groups and increases the engagement. It first started with just a survey, and a survey of about 500 people in Nova Scotia with prostate cancer, and looked at a whole bunch of different things. And really what came out of it is that we know that there are physical changes that happen with the disease and with the treatment specifically, but what wasn't really asked about or talked about, in society in general, but specifically in this group, was really the mental health and psychological impacts of the diagnosis, and also not just the diagnosis, but also the effects of the treatment. What does the side effects of treatment, how does that affect our mental health? And so there's about a 9% risk of depression and anxiety in the general population. And this survey showed that 18% or 20% of men actually had depression and anxiety, and 18% had treatment regret. And that's sort of in line with some of the other stuff that's been looked at in the literature. But this was sort of what sparked this idea of creating a program that would hopefully improve mental health, but also address all the other physical things that come with prostate cancer treatment. And so those are things like, obviously, erectile dysfunction, urinary problems, but then, you know, the other things are intimacy, sexuality, a decrease in libido, sleep problems, Murray, and then issues with relationships. And so the other things, for people that have prostate cancer, there's probably about a 2% chance of having a cardiac event, a stroke, and it's higher if you're on hormone therapy, about double, so it's about 4%. So not huge, but there is an increased risk. And so the design of the program was meant to kind of address all these things, but most importantly, make it appropriate, accessible, and easy to do, convenient, and obviously it had to be cheap as well. And so they did a feasibility study, so a phase 2 study to say and show whether or not it's safe. And they did, I think, 30 men that went through this kind of boot camp, and to see exactly how it worked, and it worked. Basically, nobody got hurt, and everybody that came out of it endorsed the program, felt it was really worthwhile. Then the next step after phase 2 comes phase 3, and that's when you look at sort of randomization. You say, okay, well, we have a group, the people that will go through this program, and compare it to people that don't go through the program. And so what are the results? And in general, my slides really were just showing all these different graphs about really the difference in outcomes for mental health, urinary problems, erection, intimacy, that sort of thing. And basically, it improves urinary and sexual function, it reduces weight, it increases self-efficacy and perception of control. And then, most importantly, it reduces psychological distress. Was it significant clinically? So, you know, we can have, you know, in medicine and in science, you'll have all this data, and it might be significant from a statistical way, but does it really make sense in the real world? And so there was, if you had somebody in the control group, so somebody that didn't go through the PCPAP and somebody that did go through the PCPAP, it was about 3.6 times higher that they had psychological distress in the control group. So it was clinically significant. And so the other thing in that trial, the phase 3 trial, was to say, okay, if we start this program at time 0, so when you are diagnosed, is there a difference between whether you start it later? And so what they did is looked at starting it at time 0 and then starting it 6 months after your diagnosis. And really, the outcomes were, it's earlier is better, so doing it right away is better. There's still obviously value in doing it anytime, and you'll sort of understand why when I sort of go through what the program involves, but it was certainly evident that doing it early at the outset was better than doing it later. So that's the why. And so what exactly is it? So it is a 6-month boot camp. That's sort of probably the easiest way to kind of think about it. And it's really to promote health and to address some of the mental and physical effects that come with prostate cancer treatment. And the website, I had a slide to show you, but we can distribute that, or Murray can email that to everybody. So what does it actually involve? So it's 6 months, and you do it at home. So you will get a daily email, and you'll get a bunch of videos. And each day, there's sort of tasks. You have essentially a set of tasks, and it really addresses exercise. So it reminds you to exercise, do strength training. So it's aerobic exercise and strength training. Also, it tells you to eat well. So it addresses some of the dietary things that it is scientifically based. So it's looking at what is a healthy diet. So it just is a kind of a reminder. So it's stuff that we should be always doing anyway, but it's a daily reminder. And then I think most of us are familiar with Kegel exercises, and so again, it goes through that as well. So exercise, aerobic and strength, and then doing pelvic floor muscle training. And then this is a thing that I should probably do as well, but it is just mindfulness, relaxation, and so there is actually a tool that they send you that helps you with what we call relaxation and biofeedback. So it's just a way of taking a moment every day and just chilling out and relaxing. And then there is instructions and discussion around some of the changes that occur with intimacy and being connected to your partners, your family. And so that's something that is unique. And we talk about a lot of things that happen after prostate cancer treatment, also physical changes, but there's emotional changes that can happen as well that we don't usually address or talk to. And we don't honestly have a lot of resource to address that. In some places there are counselors that are specialized in sexual counseling and intimacy, but they're very few and far between. There's not a lot. We don't unfortunately have many here with that training, but in the digital world, the hope is that those resources don't have to be physically present in where you live. You can connect with them anywhere. And then there's this sort of optional, what we call buddy system, and it is really meant to have that human. Basically, it's a support group, and what that means is you can sort of buddy up with a mentor, but really probably the biggest kind of part of that is really the support group. So some people opt to connect with a single person or a few people. There are mentors, and any of you, if you're interested, can become a mentor. But there is the opportunity to have a kind of a virtual support group. So every month you can connect with people through this program, or I'm not sure if people zoom into this, but yeah. So it would be sort of similar to here. If you live in Saskatoon, it's easy to come to the support group, but if you don't, this is sort of a way to kind of virtually be connected to a support group. Every week there's a survey that you submit, and again, it more or less just acts as a reminder, and it's a pretty quick and easy thing to do. So who's this for? It's meant for obviously men with prostate cancer, and as we know, prostate cancer, there's a huge spectrum. So there's people who have prostate cancer really early on, and arguably maybe not life-threatening, and then you have people who are diagnosed with prostate cancer that's very late stage, metastatic, and very, very big spectrum. And the treatments are different depending on where on that spectrum you are. How the cancer acts and behaves is different. And obviously, every person is different, so where they are in life, so how old they are, what their health is. So this is something that is for pretty much everybody, as long as you expect to live at least 2 years, so which hopefully should be most people. And you have to be safe and willing to do aerobic and strength exercises. Obviously, read email and watch YouTube, which I'm sure most of you do, or at least your kids probably do. And agree to participate in sort of these basically online quality of life surveys 4 times a year. So that's sort of the eligibility. And what are really the strengths of this program? Again, the goals are to address some of the physical changes emotional and psychological changes that come with the diagnosis and treatment of prostate cancer. So it has been successful at decreasing anxiety and depression, weight loss, and the graphs that I was going to show you, it actually, surprisingly or not surprising, really significant improvement compared to control with improved continence and sexual function, overall quality of life. And I think part of that is just, it's that, when you have, it's like, having a trainer at the gym, or if you have an appointment to make. I mean, if I have something in the schedule, I'm more likely to do it than if it's just willy-nilly and I don't have it. It's easy to make excuses not to be compliant. There's very little attrition and high compliance, so almost all people will go through the program. And again, it's only 6 months. It's safe and it's home-based. And it doesn't matter where you live. So that's the nice thing about it. I mean, you can be in urban or rural, even international. And it's cheap, it's free. And there's about a 9.4 out of 10 people would sort of endorse it. So people that have gone through it have liked it. And again, the whole concept is empowerment. It's why we use empowerment in the title is because it is about taking control of your own health. What the phase 4 part of this study is looking at is really just who would benefit the most and least from the program, and how does it vary from place to place. So, it works. It's established in Nova Scotia, but as other places use it, I mean, again, what works there may not work here. It's not really, what's nice about the program is it's not, there isn't a lot of things that would really be different from, a cultural perspective or physical perspective, because it's very basic. It's just, we all eat and we all should exercise, and that's really what it is. So it's for men with prostate cancer. What is it? It's a 6-month home-based comprehensive health promotion program for men with the diagnosis of prostate cancer. And when can you do it? Well, it's really for any time during your prostate cancer journey, but ideally at the beginning. And you do it at home, and the goal is to improve, obviously, health and quality of life. And so, any questions about the program or just about yep.
On March, May 29, 2023, they diagnosed me that I have a prostate cancer, and you are the one who did some robotic surgery on my stomach over here. 1, 2, 5. And then after that, for the last 6 months, I was not feeling better. There's a pain, things like that. And then after that, I did some Elgard injection program every 3 months with the nurse from the center, and then after that I feel better. But the only thing now is that I can do my regular exercise. I'm averaging about almost 7,000 steps at the moment. That is equivalent to 3 kilometers. From Monday to Friday, then I feel better. But the only thing that it bothers me is that sometimes when I go to the washroom, sometimes early in the morning I went 2 times, 3 times, but sometimes maybe because of that I'm drinking water 9:30 in the evening. I'm still drinking water. But aside from that, sometimes the pain is gone. But but my wife keep on telling me that is normal. Yeah. Because my wife is a nurse from the university hospital in the coronary care unit and intensive care unit. She works there for the last 45 years. Yeah. So he said to me, "Don't worry about it. That's the sickness of the old people."
Yeah. Yeah, and it's interesting, your journey that you mentioned there, because, various places across the country have various weights between the diagnosis and treatment. I know when you are diagnosed and you decide on treatment, you want to get it done right away, and there is just the system we have to navigate. But we actually are pretty fortunate. Things are a lot worse in other places. So, a 2 or 3 month wait for surgery seems like an eternity, and that's not ideal. But there are places that are waiting more than that, and actually, in Nova Scotia, they wait a long time. So, when you're diagnosed, and let's say you want surgery, they were surprised that we do surgery so quickly. There's obviously going to be limitations after surgery as far as what kind of exercise you can do, but it's not a lot, and especially with minimally invasive surgeries, the return to normal activity is a lot quicker. But there's a brief break, so when you are diagnosed and you go through the boot camp, it continues. So it doesn't really stop. The only thing that stops is what your physical limitations are for that period of time. But you do all the other things. So you do the Kegel exercises, you eat well, you can still do some strength training, but obviously with the limitations that come with recovering from surgery.
That program here?
Yeah, it's live. It's not so.
Oh, okay.
Yeah, so it is. It's an option right now, and has been for a while. Currently now, when you are diagnosed, people that have gone through the pathway have, they get a big package of material, and this is often part of that. It's just a one-page thing, and it's really just to direct you to the website. And once you go to the website, you can navigate it and decide if you want to enroll or not. So it's an option. It's still virtual, so it's really, you do it at home. All the instructions are email and on those YouTube videos, and it's really self-directed, but with regular reminders.
If you have any questions, sorry, this mic hooks into our system so we can hear it. We can't hear it on the video, so if you have a question, come and grab this. I'm not delivering it. Sorry. Thanks.
I'm not going to sing it. It's not working. Is it working?
Yep, it works.
I don't know if this is part of the study. In that study, does it shows that for any age group that was diagnosed with prostate cancer, and how to deal with their anxieties? Because, different age group might have different level of anxiety.
Yeah.
Do you know what I mean?
So it is for, it's for any age, and any treatment modality. So, and even, like I said, active surveillance is even an option. So people have active surveillance or active treatment or metastatic disease. So all ages and all comers. The tools and the things and the benefits are going to be variable. So, yeah, I mean, we're all, our bodies and our brains are all wired differently. So there will be some, everybody, the impact on mental health will be different from person to person, just like the physical impact. But it is more kind of generalized, not targeted. If that makes sense. Okay, great. So then the next thing, and again at the end, I mean, we can just, you guys have other questions or comments, we can certainly do that. It doesn't have to be about the PEP program or robotic surgery, but this will be very brief. Without the slides, it's not really that helpful, but and that's okay if
Take the cheesies back.
yeah if you so I think most of you are aware that we are now have evolved over time here with our approaches to treatment. Things have come a long way in general for prostate cancer treatment. When I look younger than I am, but part of that is just my mom's genes. I'll give her credit for that. But in my career, and it's almost 20 years now, that I've seen a huge evolution in treatment and our approach to prostate cancer, and that, where, when I remember we would, only operate on people with low risk disease when I was training, and now, you never operate on people with low risk disease. We've learned a lot more. The disease hasn't changed, just our understanding of the disease has changed. And now, we really mainly operate on intermediate and high risk and use active surveillance for some people when appropriate, and then, lesser invasive options when possible. And that's same thing with surgery. So our understanding and our approach to prostate cancer has changed, and so has our approach to surgery. And one of those things is robotics. And robotics isn't new in the world. It is new for us, relatively new, although it's actually been 2 years, which is crazy that it's been 2 years now. But what the benefits, or at least the idea of robotic surgery, I mean, the reason that's part of the evolution is just, technology changes. We know that with our computers. They don't always work the way we want them to, but they do a great job when they work. We were very lucky to have innovators here in Saskatchewan, and so one of my colleagues and mentors, the person that actually made me become a urologist, is one of the pioneers of laparoscopic surgery. And I would say good and bad. The good news is that we became experts at laparoscopic surgery, so much that we were actually one of the only places in Canada that did laparoscopic surgery for almost 20 years. And then, and the reason is it's a hard operation to learn and master. And then other places bypass that, and they were doing open surgery up until recent, and then because of the robot, it's allowed people to do laparoscopic surgery that didn't previously know how to do it. So it's sort of, in a good way, has sort of allowed minimally invasive surgery to become more ubiquitous. But that's the reason that we've been only doing it for 2 years, because the sort of the benefits and gains of minimally invasive surgery were already had with doing it laparoscopic. And so the actual technical aspects, what happens, is the same, whether you do it laparoscopically or robotically. But the instrument's a bit different, and the ergonomics are different. And we felt that we didn't know if there was going to be a huge change. But that's what I sort of wanted to share, is sort of what our experience has been since we've been doing it for 2 years now. With robotics, so the big benefit is that, like I said, people that can't do laparoscopic surgery can maybe now do it, because it's easier to do ergonomically. And there are some fine parts to surgery, so some technical things like suturing and certain dissection in very difficult places to get to. So nooks and crannies. The prostate is a hard area to get to compared to a gallbladder or a kidney. And so, and this all actually started, robotic surgery, the first service was cardiac surgery. Didn't actually take off, but because the heart is a hard place to get to, and that's where they sort of initiated robotics. But with endovascular things, so people with angiograms, it's much easier to do it that way than actually, so cardiac surgery has sort of gone a different route. But what we weren't expecting, what we thought was, okay, we would bring in robotics and it would make it easier for us. And certainly there are some physical challenges in doing surgery in general, and especially challenges to doing laparoscopic surgery, which is why a lot of places gave up and didn't adopt it, because it's hard to do. And so there's a physical toll on that, with that. So robotics has certainly made it a lot easier. I was going to sort of show you on a diagram, really what it looks like physically. So the robot itself is in the room over top of the patient. We're still in the room. We're just at a little console beside. And the robot does not do the surgery. It's right now just a tool for us to control. But, who knows what the future holds. But it is really just a really, really expensive instrument that allows us to do more fine procedures. But when I first, did one, I thought, okay, well, there's really no difference between this and laparoscopic surgery, and it really isn't. When you watch it and you look at it, it doesn't really look any different, other than the instruments move a little bit differently. So as of now, what we've learned is that, okay, well, we didn't think it was going to have that big of an impact, but for whatever reason, and I think I know why, but compared to laparoscopic surgery, which again, same number of holes, people had less pain. And at first couldn't really understand, and then because of that, most people, went home the next day. And compared to before, now part of it is just, we had previous habits of, keeping people in for a couple of days, and that was just habit. But, the occasional person previously would go home the next day, and I would say maybe 10%. Now about 80% go home the next day. And part of that is just there's less pain. And, if you think about why would 5 holes with a robot be any different than 5 holes with laparoscopic surgery? It doesn't make any sense. Because, and actually, the holes are even smaller doing it laparoscopy. They're slightly bigger, a couple millimeters bigger with the robot. And the reason is, at least what I think is that the robot, when we do laparoscopic surgery, we have to torque the instruments, and we're torquing the instruments when we need to, and it's pushing on the abdomen, and it's maybe causing a bit of muscle bruising or at least strain. But the robot has it's really smart. It has a fixed point, so it does not torque. If it needs to move, it doesn't torque on the skin. It moves it's sort of a pivot. It's got a central point, so it doesn't move. So there isn't, even if we have to get to the certain place in the same way, there's none of that torquing on the belly, on the body wall. So that's probably what it is. But bottom line is the results were surprising to us because we weren't expecting that. And to date, we've done 362 surgeries for prostate cancer. Again, the pain is less afterwards. Most people go home the next day. And because of how we initially didn't want to make major changes, but we had heard that other places no longer use drains. We didn't really believe it, but what we have found is that really almost nobody leaks afterwards because of how precise we can bring the urethra and bladder together afterwards. And so, unfortunately, you still have a catheter, but we rarely use drains now. I would say probably maybe 5% of the time you need a drain afterwards. Now, is that a huge deal? Well, there's one less thing to worry about, one less potential site of infection. And so I would say an unintended benefit. And then probably the two big things obviously is whether or not it makes any difference functionally. And unfortunately, it's still probably too early to tell from a functional standpoint, because the issues with continence is kind of a longer term thing. But what we have found, and this is more anecdotal, but and the reason it takes a long time is that, we don't know how many men need surgery to repair their continence issues for, a good year or two. And so we're at that 2-year mark. And as of now, nobody is on the list for reconstruction for their continence, which is, I would say probably a lot different. It would be about 10% prior to that. But what we are seeing is that almost everybody is getting their control back a lot sooner. And, I think it is just for 2 factors. One is because of what we can see and how we can manipulate things with the robot, we are able to get a lot longer length of the urethra without sacrificing the cancer operation. And then that also, bringing it back together, the sewing is a lot more precise. And so I think that combination is likely contributing to getting your bladder control back. We've known prior that there's a few things that, obviously, the younger you are, the more likely you are going to get your control back. And the length of the urethra and how well things come together are probably the 3 big factors that are important for continence. Initially, when we started, there's always a learning curve. And because we were so experienced with laparoscopic surgery, initially when we started, we thought we'd made a huge mistake because it was taking a lot longer. There was lots of, logistical things to learn and figure out with the robot in the room and preparing everything. And so surgeries were taking about an hour longer than usual. And that's not insignificant, but we were, and when you've done something for so long and you're so used to doing it, it's easy to sort of think, well, why am I doing this? I could have been done an hour ago. But it's just a matter of time. And so it's just a matter of getting all those little things ironed out. And we're probably back to sort of what we were doing it laparoscopically within a few minutes on average. So that's sort of where we're at with robotics. A lot more experience. We've learned a lot more. I think the functional stuff is still to be determined, but in the short term, for sure, men are getting their control back sooner than they were prior. The long term, whether it doesn't, we knew with laparoscopic versus open, it was better, but in the long term, men just get there eventually. It just takes longer, and probably in the long term, it may not make a huge difference, but getting your control back sooner is always better. And as far as the erection, so that's another big thing where historically, obviously, when we do surgery, erections are going to be affected, and in most cases, they're going to be gone completely. With nerve-sparing surgery, and nerve-sparing surgery, again, is not, doesn't mean you're going to have normal erections, but the ability to actually spare the tissue is a lot better, and it's mainly because of the visualization. So when you see the actual image in the room, it doesn't look any different than laparoscopic, but when you're the surgeon, you're actually looking things in 3D. And the instruments also allow for you to dissect the tissue away with that 3D image. And our ability to actually do nerve sparing is a lot better. Now, it's really too early to say whether or not that has changed anything, because nerve sparing still has to be appropriate. So we don't do it just because we have a robot. You have to do it if the setting is appropriate. So because we are doing surgery on men that have higher grade disease usually, we wouldn't be doing nerve sparing. But if it's appropriate, we haven't done a lot, but when it's appropriate, it's certainly a lot easier. And whether or not, again, the results of nerve sparing are still, not great, but that's just the nature of nerve sparing. Any questions?
Nerve sparing is the holy grail, isn't it, for men?
Yeah.
A lot of men.
Yeah.
That's what we hear, that there's an opportunity to get some nerve sparing. And even if it doesn't work, it gives you the confidence, it gives you a mental boost, I think.
Yeah, and part of it's also just the technique and dissect. If you spare the nerves, and that's also one thing that even if nerve sparing doesn't preserve erections, it also has been shown to actually improve continence. And it's more about preserving some of that tissue around the prostate. So even though the intent of nerve sparing isn't for continence, people who have nerve sparing tend to have better continence afterwards.
How many in your group are perform the surgeries, like the robotics?
Yeah, so there's 4 of us, and so they're the same 4 that did laparoscopic surgery, do robotics, but we have 2 more. One is actually down training at the moment, getting his certification, so he'll be joining it. So there'll be 5 of us, and then another one will be doing robotics, but not prostate cancer surgery.
And how many surgeries are performed in a day?
So it depends on who the surgeon is, and what type of cases. So initially, because we were learning, we were probably doing 1. Historically, we would do 2 prostates in a day with laparoscopic, and now we're back to doing that now as well. And it's just a matter of just the efficiencies that we've gained. And so now we're doing 2 a day. And there is a possibility of 3, but we don't want to stress the system too much that way.
What's the time frame? Like 3 hours? Is that normal? Or?
Yeah. So the person's in the room for about 3 hours. The actual surgery itself is about 2 hours, maybe 2.5 if you're having lymph nodes removed as well. But the actual surgery time is about 2.5 hours.
Dr. Jana, I don't believe you remember me. If you don't, you're the one who, did the prostatectomy some 3 years ago. Unfortunately, I was a bit too late for Da Vinci, as you call it. Now, with that in mind, I have a rather half-baked question to ask you. Some 3.5 years into my prostatectomy, I still struggle with incontinence, especially under stress.
Yep.
So my questions are twofold. Okay, precisely, and I've done a fair bit of reading on this, like on my own. What is the exact anatomical basis for incontinence after you remove a gland? Surely it's got to be more than muscle loss, because I am doing the heck out of my Kegel since prostatectomy.
Yeah.
So there's got to be more to it than that. If there is, maybe you can share that with us, because I understand it's common to a number of us in the group here. And I was very happy when you sort of like briefly alluded to the fact that you might be able to use robotic surgery in order to restore continence in patients. I would like to know more about that, because I'm getting tired of this shit. It's just
It's not, yeah,
frustrating.
yeah, robotics, it won't correct continence, but the hope is that it'll reduce the impact of it and quicken the recovery. But the physiology of why incontinence occurs. So incontinence in general is just, loss of urine when you don't want it to. And so our bladders are a fairly complex organ in that it's meant to store urine until it reaches a certain threshold, and then when it reaches that threshold, it needs to empty. And if it doesn't, then you'll be in pain, or if it happens very gradually, it can lead to other problems like incontinence. And that's a different type of incontinence, but it's where you overflow and you leak, or it eventually causes kidney failure and such. So that's the purpose of the bladder. The control mechanism of the bladder is twofold, and that is there's a involuntary control mechanism. We call them the sphincters, so an involuntary sphincter and a voluntary sphincter. And the involuntary control mechanism is these muscles that you don't have necessarily physical control of, or not like the muscle in your arm where you want it to do something and it'll do it. It's something that's involuntary, and the external sphincter is voluntary. That sort of involuntary muscle is in the prostate, and not just the prostate, but the opening of the bladder. So we are removing, or whether we do surgery or we do radiation, we're removing or destroying that internal sphincter. So you're going from two mechanisms to one mechanism, and one mechanism that your entire life has not had to do anything, because really your whole life, your internal sphincter is doing pretty much all the work. But then you remove that, and now you have to rely on this muscle that for your whole life has not really had to do anything. And that's why you leak. And so the type of leakage is called stress incontinence, and it's basically just that the control mechanism. And stress incontinence happens even if you have an internal sphincter, but it doesn't usually happen in men because we have long urethras, and if you have a weak internal sphincter, there's less leakage just because of the anatomy. But women have a short urethra, and their pelvic floor, which is what is part of that external sphincter, is it's more profound when it's weak because of that short urethra. But in men, until we lose that internal sphincter, really that pelvic floor has not really had to do anything. And that's really the mechanism behind leakage after prostate cancer treatment. And so it's so variable as to how much strength you can get, and it's also something that right now, after you have treatment, you have to think about it, and you have to constantly think about it. And when you don't, you're going to leak. And the whole idea of pelvic floor physiotherapy and those Kegel exercises is for it to become a habit that you eventually don't think about. So, you're going to be squeezing those muscles without thinking about it, but initially you're going to be thinking about it all the time.
Another thing that, if I could add something to that, based on personal experience, if you rely on what you're taught when you're first diagnosed or when you're first treated about how to Kegel and the different kinds of exercises, if you rely on that, you're doomed, because you forget. And it's a good thing to go back every once in a while and see a pelvic floor physiotherapist, because they can help you. So I was having trouble, and I went back to see one a couple of months ago, and she helped me pretty quickly. So, and that's after 11 years after the surgery. So you never, you don't necessarily lose hope. It can help, you can be helped still. But the initial exercises that I did, I'm not doing them anymore. I'm not doing anything like that. I'm doing stuff that's totally different.
What were you doing then?
I was just doing a straight Kegel, just hold it for, 20 seconds and let go. I don't do those anymore. I do exercises for my whole pelvic floor and my whole core, and it's changed how that all works. But they're all, because I'm being taught by a pelvic floor specialist, she's making sure that I'm doing Kegling as part of these exercises. So it's sort of strengthening everything, not just the specific thing. And it helps. So.
Yeah, it's a good point in that our bodies change, we get older, and so what you do initially may not work, and for other reasons, like not because something bad's happened or that you're doing something wrong, yeah, but you might have to adapt.
Yeah.
And so, we're very lucky because we actually have pelvic floor physiotherapy as part of the pathway, and they're a resource. There are pelvic floor physiotherapies outside of the pathway, but there is funding for people that are struggling after prostate cancer treatment.
So should somebody like Adam talk to Nicole or something like that?
Yep. Yeah.
There you go.
So if I'm understanding you correctly, the odds of surgical intervention is not.
Well, it's
Like one checkpoint is
Yeah,
no longer there.
yeah. So there is. Yeah. So there are. So Dr. Chan, my colleague, he's our specialist. That is our what we call reconstructive urologist, and so he specializes in pelvic floor. I would say reconstruction a little bit, but it's for men after prostate cancer treatment. There's two options depending on the severity. The most severe get what we call an artificial sphincter. So it's basically an implant. It's a prosthetic implant, but it's a valve, an artificial valve that we put in that there's a little button that's embedded that you push to release when you want to avoid. But it's tight all the time, and there's a mechanism in there where the button you push will drain the fluid in the control mechanism, the sphincter, when you want to pee, and then it fills up slowly. And so that's the most severe. The other, depending on the severity, there's something called a mid-urethral sling, which is similar to like a bladder lift in women. It's a little hammock that's put underneath it. So it's not as involved as a sphincter. There's nothing that you need to control. It just gives it a little bit more support. But the effectiveness of that is really for more milder forms of incontinence. So if somebody's diaper dependent, then a sphincter would be likely what you need. But if you're leaking but using pads minimally, then the sling might be the way to go.
For me, in my opinion, for myself, I think robotic surgery is a good for me.
Yeah.
Because I changed my life. Because before I go for this robotic surgery, every time I go to the washroom, there's some blood coming out in my urination. And then my family decided already, you better select which one do you like, radiation or the robotic surgery. So I did robotic surgery for my first 6 months. It's a pain, but now, after almost a year now, because my surgery was made in 2023, and then I feel better now. I do my exercise. Sometimes 9:30 in the evening, I still drinking water. So my wife said, don't drink too much water in the nighttime because you're always going to go to the washroom. And then the second problem now I'm getting now is that my erectile dysfunction is there. But I'm so happy because I'm already 75 years old. I don't need that one anymore.
It's wishful thinking now.
Yeah.
I don't need it anymore. Every time I do babysitting my grandchildren, I'm so happy.
Yeah.
I just go day by day for myself, and the second thing that it helps me better is that
Yeah.
I'm doing this for the rest of my life. You know, I'm so happy now.
Dr. Jana, how amenable is the robot relative to laparoscopy in removing, say, lymph node or foci or metastatic foci? Is it equally?
Yep. Yeah, it's, yeah, the surgical technique is not any different. It is essentially laparoscopic surgery. It's just a tool to allow us to do it, I would say, easier and better. But what happens on the inside is the same.
I heard one doctor describing the difference between laparoscopic and robotic. So laparoscopic, the range of motion of the arm was at the end,
Yeah.
and robotic.
Yeah, so,
that right?
yeah, so if, you know, doing laparoscopic surgery revolutionized surgery. That was a huge thing, and again, Don Fenty, he was a pioneer, and he was the first urologist in Canada to do laparoscopic surgery, and that was in '93. So, but that, you know, you have, it's really like using chopsticks to operate. I mean, there's very limited range of motion with pure laparoscopic instruments, but you learn, and that's why there's certain surgeries you can't do laparoscopically that now you can do with robotics, just because of the ability to move and get into the little nooks and crannies that you can't do with just regular laparoscopic surgery. And that's really where the benefit, I think, is. I mean, now, there are lots of things, laparoscopic surgery came a long way, but it's sort of at its limit. And so robotics is sort of taking it to that next step where we can get to places we couldn't normally get to, or do some more finer surgeries in these little nooks and crannies that we couldn't normally do. And it's because, you know, that's when laparoscopic surgery came around, there was, you know, lots of uproar and people that did open surgery because, you know, how could it be any better than having your hands in there? Like, you should be able to feel everything. And but, you know, that you realize that that's not the case. Although, what is the difference is that, you know, your hands can move in lots of different directions where the laparoscopic instruments can't, and that's what the robot's done. It's sort of melded both. The one difference is that with laparoscopic surgery, there isn't a tactile feedback, but there is what we call haptic feedback. So you can sort of feel how things move and what they are with the instruments, which you don't have with robotics, because you're not touching the instrument, so you don't know how it feels in the body. But over time, you sort of start feeling with your eyes, so you know how it's just a muscle memory thing, where you know how the machine looks, what it would feel like. But the next generation actually has haptic feedback, so they've built the newest robot with the ability to give the surgeon haptic feedback, so it's coming a long way. Yeah. Which is, I've only just read about it, I haven't seen it yet, but it's pretty crazy.
I had a question on the internal sphincter and the difference between radiation therapy and surgery. The internal sphincter, is that kind of inside the bladder? How close to the wall? Because radiation has a spillover or innocent
Yeah.
bystanders, as they talk about. So
when-
how is radiation different than surgery with regard to the
Yeah,
internal
so
sphincter?
I would sort of think about it as the same. So the internal sphincter is in the prostate and the opening of the bladder, if you want to think of it that way. And that's what is radiated. So because the prostate's radiated, the internal sphincter is radiated. And, in all intents and purposes, it's removed with radiation, it's destroyed, so it doesn't have any actual effectiveness. Although it's still there, so it's destroyed, but it's still there. So you won't have that severe leakage up front because the radiation damage happens over time. Just like the issues with erections, it happens over time. So that's why when people get radiation at the outset, they have pretty much normal control. But as time goes on, and if you look at the data, it'd be about 3 or 4 years down the road, it's the same. The journey is different. So people are dry initially and then get wet as time goes on after radiation, whereas people are wet after surgery but get drier with time. So the journey is different, but the end result's the same. And so but the internal sphincter is destroyed. It just doesn't happen immediately, whereas with surgery it happens immediately because it's gone.
So then the follow-up would be, if a person's had radiation, it's delayed, as you say. Should a person be learning the Kegel and going through that process, or is there any advantage in going through that process in advance versus waiting until, you start to have those symptoms?
Absolutely, yeah. And that's actually what that PCPEP program is all about. It's, you start at the time of diagnosis, so you're going to be doing physical activity, exercises, and also Kegels at the outset, and learning how to do that, so that, and it's for 6 months, but in that 6 months, hopefully you'll gain those habits and then continue that on. So later, when incontinence starts to happen, you'll have that skill set.
Any other questions? No. That's great. Thank you very much.
Yeah, you're very welcome. Yeah, thanks for having me.
Sorry about all the issues.
Oh, that's okay. Yeah.
No, it's not. This has become my life. Yeah. Screwing this thing up. I gotta get my little doodad here.
How many of the cables? 3 of you. Okay, so that's why.
So at the moment, we have two main services, actually 3. So thoracic surgery. Those are the 3 services that we use.
That's so frustrating.